Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our conversation with Cancer Expert series, we have Dr. Jeffrey Zonder with us. He's professor of medicine at Wayne State University, a leading figure in the plasma cell dyscrasia space, right from smoldering myeloma to multiple myeloma to even amyloidosis. So we're going to today talk, however, on smoldering myeloma, to treat or not to treat. Welcome, Jeff.
Thanks so much, Ravi. I really appreciate the invitation to come speak today. This is a complicated topic.
It is, and getting more complicated by the day, and more controversial by a little bit as well.
Let's tee up the talk by just discussing what smoldering multiple myeloma is.
Sure.
Remember that symptomatic myeloma always arises from a precursor stage, monoclonal gammopathy of uncertain significance. And by definition, MGUS has no symptoms and less than 10% bone marrow plasma cells. Once you cross that 10% threshold, or 3 grams of M protein, but we really focus on that 10% threshold. We start calling it multiple myeloma, and if there's no symptoms, still it's smoldering multiple myeloma. And as the bone marrow plasmacytosis keeps increasing northward of 10%, the likelihood of symptoms goes up. The likelihood of progressing to symptomatic myeloma after the initial diagnosis of smoldering myeloma is not the same for every patient. Here I'm showing you the traditional CRAB criteria that we think about for multiple myeloma that requires treatment, and the more updated SLIM CRAB criteria, which includes some other laboratory or imaging parameters for therapy requiring disease. But the important take-home point, I would say, is that the annual risk of progressing from smoldering myeloma to symptomatic treatment requiring myeloma is not the same. It can be as low as 5% for some patient subsets, or as high as 25% chance per year in others. We call that latter part high-risk smoldering myeloma.
So I guess the debate is to treat or not to treat, and I think most people, at the moment at least, don't even debate the low risk. It's really in the high risk smoldering myeloma that I guess this debate exists.
That's right. We're going to go through several studies that have been done that show that there may be benefit in terms of delaying progression to symptomatic myeloma with treatment. But first, let's just talk about treatment philosophy, right? Because there's different ways you might go into this. One general strategy is the idea of kicking things down the road. And what I mean by that is, your only real goal is to delay the onset of symptomatic myeloma. And generally, if that's our goal, we want to do that by avoiding toxicity. So we're thinking about milder and finite therapies, right? Because we have a low tolerance for side effects, if we don't believe we're actually curing any patients. Now, the other strategy that you could take, or the rationale for treatment, right, is to try and cure the disease, where you're using more intensive therapy, where you might accept a longer duration of therapy or more side effects, because what you're trying to do is eradicate the smoldering myeloma completely and prevent disease altogether, effectively curing patients. The rationale for treatment, isn't for early treatment really isn't just preventing the emergence of a single resistant clone. It really has to do more with preventing high-risk molecular features and clonal diversity, because as the disease becomes more complex and there are more subclones, there are more opportunities for resistance to emerge later, right? So that hard hit early kind of is the rationale for more intensive therapy.
So I guess we'll first review some of the low intensity strategies that have been tried, and then obviously go on to the more curative approaches. So I guess the trials that you're going to talk about are going to start with the QueerDex trial and then some of the other trials as well. So, what can you tell us here?
Well, I would say that, the lower intensity strategies are definitely the ones that are more commonly considered. I think both clinicians and patients tend to think about these kinds of strategies because, again, by definition, these are asymptomatic patients, right? So there's a desire to maintain quality of life. I'm going to talk about a pair of studies that were done at different times, focusing on the use of lenalidomide as a treatment strategy. The first one is called the QueerDex study. This was a Spanish study that involved 119 patients with high-risk smoldering myeloma. Their definition of high-risk disease included what many of us will call like the Mayo 20-220 criteria, which has to do with the long and short of it focuses on the percentage of bone marrow plasma cells and the degree to which the M protein or serum-free light chains are elevated. Or a different criteria where they measure they analyze the percentage of clonal plasma cells out of the plasma cells in the bone marrow. That's not a strategy that is commonly employed in the United States and not as easy to do, certainly, as simply measuring labs. But anyway, in this study, the initial design was lenalidomide and dexamethasone for 9 cycles, followed by indefinite lenalidomide versus observation. And then the study was modified to limit the lenalidomide to a total of 2 years. And the primary endpoint in this study was progressive disease. What they found on this trial was that the median time to progression disease in the observation arm was 21 months, and it wasn't reached in the initial reports in the lenalidomide arm. So it was a positive study. One important thing to note in this study, because it's relevant to some other facts that we're going to talk about in a few minutes, is that once patients in the observation arm progressed and went on treatment, it generally wasn't Len-Dex treatment. It was other regimens that were in use at the time. So that's the first study. Now, the second study was E3A06. This was an American intergroup study led by Dr. Loniel, and this was a study that included intermediate or high-risk smoldering myeloma patients. It was bigger, 182 patients. This study compared lenalidomide given for 21 out of every 28 days in repeating 4-week cycles on an ongoing basis until disease progression or observation. Again, primary endpoint, disease progression, and 3-year progression-free survival is shown here. PFS was 91% in the lenalidomide arm and 66% in the observation arm. So quite a significant improvement in delaying progression to disease. But this was almost entirely driven by the high-risk patients. So, even though the study as a whole was reported as positive, a more nuanced look at the results tell us that it was really the high-risk patients that that derived the benefit. And if one were considering treating smoldering patients based on this, it should be restricted to patients who are high risk by the 20-220 criteria that I mentioned before.
So, how did the primary outcome that we care about, which is survival, fare in these 2 studies?
Right. So, one might have predicted that there would be no differences in survival because we were treating early patients who didn't have any disease-related comorbidities, and presumably with initiation of prompt treatment on progression, you would avoid early survival differences. And in fact, that is not what we saw in the Quiridex trial. We saw, on the first panel here, we're looking at the progression-free survival. And again, the observation group did about what we would have expected. For a high-risk smoldering myeloma group, about 25% per year progressed, much different than the treatment group. It's the right panel that caught everybody a little bit off guard. There was an overall survival difference seen here. Hazard ratio was 0.43. It probably speaks to a couple of different points. I mean, the first is that the timing of treatment initiation, right, could certainly drive this second outcome of overall survival. What you used when patients needed to be treated, but also when you started treating them. And if you didn't treat them at the time that we might, in the United States, currently treat patients, you'll have more disease-related morbidity and mortality. And I think that's probably what we saw here. I think also just speaking to the really wide difference in PFS, I mentioned that, high-risk smoldering myeloma can have a progression rate as high as 25% per year, but we also actually saw, even in the treatment group, a fairly brisk rate of progression. It may have to do with the way patients were screened, like the inclusion criteria and the way we categorize disease on this trial. Advanced imaging like MRI imaging or PET-CT imaging was not required on this study. And so there's some likelihood that patients who may have had actual symptomatic myeloma using current slim crab criteria were probably included on this trial. Outcome difference, survival outcomes in the E3A06 trial were, I think, more in lines with what we would probably expect from a smoldering myeloma trial. You can see here, again, there's a significant difference in PFS, but it's not nearly as splayed apart, as it was in the Quiridex trial, right? Again, part of that is probably the inclusion of intermediate risk patients, but there was also no survival difference seen on this study, right? This trial, you can't compare it really directly with Quiridex because the patients were different. There were lower risk patients included on this trial, but it is encouraging to see that the survival of patients, including the survival of patients who had progressive disease, was better than what we saw in the Quiridex study. Interestingly, one of the secondary endpoints on this trial was quality of life, the quality of life measures on this study did not actually statistically differ, but I always take that with a grain of salt too. Having treated many patients with lenalidomide maintenance therapy, after transplant, I think all of us understand that adverse events happen. Grade 3 adverse events in this study included up to like 50% of patients, and the median duration of treatment was 23 months. Even though not a quarter of patients progressed in the lenalidomide-treated arm. So patients came off therapy for varying reasons in the lenalidomide arm over the course of this study.
Good. And did the subset analysis give us any clues?
It did. The benefit, as I mentioned before, was most pronounced in high-risk patients. There were some other subsets, like, again, you couldn't say that statistically the intermediate risk patients derived the same benefit because the confidence intervals crossed 1, as you see here. But for most risk groups, Mayo 2220 risk category, age, sex, performance status, it all tended to sort of fall on the same side, favoring lenalidomide, and roughly to the same degree in terms of the hazard ratio. The one standout, which didn't really get all that much attention, but I don't think should be ignored, was that Black patients actually did fall in the other direction, and it was the only subgroup in this particular analysis that fell in the other side. It may just be a function of small numbers. You can see here the very wide confidence intervals, but it's the kind of finding that reminds us how important it is that we make sure that there's broad representation in clinical trials. And in myeloma, where Black people have twice the risk of developing myeloma, it's important that we continue to include them and go out of our way to make sure they're represented adequately in studies like this.
So one of the more recent trials is the Aquila study. This looked at daratumumab instead of Revlimid. Can you tell us about this study?
Yeah, this is a study that generated a lot of excitement. And part of the reason for that excitement, I think, is that, again, clinicians and patients view daratumumab, which is a anti-CD38 antibody, as maybe an easier therapy than lenalidomide. It's a subcutaneous injection. It ultimately can be given every month as therapy without other treatment in between. And so the results of this study, I think people were quite anxious to see these results when they came out. This is the design of the study that we're showing here on this slide, as reported by Dr. Demopoulos at ASH last year. And this included, the definition of high-risk smoldering myeloma used in this study was a bit different than in the other studies. It was at least 10% clonal bone marrow plasma cells and one or more of the following three things, or four things rather. An M spike over 3 grams per deciliter, immunoparesis where the other two uninvolved immunoglobulins were depressed compared to the clonal immunoglobulin, a free light chain ratio that was greater than, an involved to uninvolved free light chain ratio that was 8 or higher, but not 100, because that flips into the definition of slim crab, defined myeloma. And then or clonal bone marrow plasma cells that were actually quite a bit higher than 10%, in the 51 to 59% range. And then patients who met these criteria were randomized to either daratumumab at the schedule shown here, and this is the typical schedule of daratumumab: weekly for 2 4-week cycles, then every other week for 4 4-week cycles, and then after that every 4 weeks, up to a total of 36 months, which, if there were no interruptions, is a maximum of 39 cycles. And this was compared to active monitoring, and the primary endpoint in this study was progression to slim crab positive myeloma. And the way they assessed these patients was to check labs every 12 weeks, imaging annually, and bone marrow biopsies no less frequently than every 2 years. Primary endpoint, again, the PFS, but they looked at other endpoints like overall response rate, time to treatment, etc., and survival.
So what were the demographics of this population?
Predictably, based on the eligibility criteria, again, different than what we saw in the other studies. And so if you were just looking at, for instance, the 20-20 criteria that I mentioned before, Actually, only about 3/4 of the patients, or three-quarters to 80% of the patients, fell into intermediate or high risk, and not even half of the patients fell into high risk 2220 criteria. So this was not quite the same patient population that was treated, for instance, in Dr. Loniel's lenalidomide study, right? Even there were patients included in this study who didn't even meet intermediate risk 2220 criteria. So a little bit different, right? And also, most of the patients in this study didn't have high-risk cytogenetic and FISH abnormalities either.
And what were the results in terms of the primary endpoint?
So what we see here is that PFS, progression-free survival, did definitely favor daratumumab compared to active monitoring. There was a little bit more of a drop-off, in this even on the treatment arm compared to what we saw in the lenalidomide trials. A little bit surprising. Perhaps it had to do with the endpoint being slim crab, criteria as the definition of progressive disease. But 80% PFS at 2 years. That is a little bit lower than I might have expected. For a group of patients that included low and intermediate risk 2220 patients. That said, there still was quite a difference between the treatment group and the non-treatment group. So there was benefit, but it's a little bit hard to tell if the benefit was as pronounced as it was with the other maintenance, the lenalidomide-based strategies that we used, right? I mean, that's a difficult one. If we drill down to, of the people who met criteria for progression, how many of them had progression that we would consider to be symptomatic progression? Because I would say that in clinical practice, when someone's serum free light chain ratio drifts to over 100, or they have a bone marrow biopsy that shows their clonal plasma cells have gone from 55% to 62%, that would not necessarily prompt treatment, right? They meet slim crab criteria. It trips the endpoint on a study, but in terms of symptomatic progression, if we look at the difference, there were 48 symptomatic progressing patients, and because I count bone lesions that are found on an MRI, that counts as bone disease in my book. 48 patients had symptomatic progression in the observation arm versus 24 patients in the treatment arm. So 24 patients didn't have progression that would have if they'd only been observed over the course of this study. By my calculation, if I did the math right, the number needed to treat is 8 or 9 when you look at it that way.
So can you identify a subgroup that you could consider using this approach in?
Yep. So I think, not surprisingly, the group that benefited the most was the high-risk patients. And if you actually look at the patients with lower intermediate risk, although they did have a favorable hazard ratio, the confidence intervals for those subsets crossed 1. So statistically, the PFS benefit seems to have been driven by the high-risk patients. The other thing I would like to point out is in this particular study, although again the confidence intervals were not were very broad, and so you couldn't say it was you can't say with certainty that it's statistically true, but non-white patients seemed to fall in the same general direction in terms of benefit as white patients, which is I think reassuring and very different than what we saw on the ECOG lenalidomide study.
So what about survival, once again, which is the most important endpoint clinically?
Yeah, so with long follow-up, we actually did see a slight and statistically significant survival difference on this study. So I mean, this was a large study, and there was long follow-up, and eventually, at the 5-year mark, there was a 93% overall survival in the treated group, and in just shy of 87% presents overall survival in the monitoring group. And this mostly seemed to be driven by the progressive disease as the primary cause of death. So the differences related to adverse events and other causes was very similar between the arms, but there was a difference in the risk of dying from progressive disease.
And how safe was this approach?
Well, quality of life didn't seem to be affected much by being on daratumumab, according to the surveys that patients completed. But there certainly was a higher rate of side effects in patients treated with daratumumab compared to active monitoring. We can see here on this slide that there was a significant increase in fatigue and the risk of infections, diarrhea, and some other maybe less specific symptoms like back pain and arthralgias. These did not tend to be severe adverse events, and when you look at the overall rate of grade 3-4 adverse events, there was about a 10% difference, but only about 5 to 6% of patients in the DARA group actually discontinued treatment because of adverse events. And the adverse events that led to death on the study in the DARA arm were COVID infections, and that reflects when this study was actually conducted. Also, no difference in the rates of second primary cancers seen on this study. I actually found the rate of secondary cancers interesting. I mean, it just reminds us that myeloma patients or patients with plasma cell dyscrasias and lymphoproliferative diseases have a higher rate of second cancers compared to the general population. And it was about 10% in both arms on this study, even though they didn't get any of the drugs that we as myeloma physicians often think of as being culprits for secondary cancers, like IMiDs and alkylating agents. Didn't get those drugs, right? So this just talks to the sort of the background risk that we should all remember.
So I guess we'll switch gears and talk about the other approach, which is hit it hard in an attempt to cure it.
Right.
So what do we know here, I guess?
Well, there have been a few studies done in this area, and they actually have sort of employed similar strategies until quite recently. The GEM CSAR study is one such trial, and I'm showing you sort of the general design of this phase 2 study here. This is carfilzomib, lenalidomide, and dexamethasone, followed by a standard bone marrow transplant, followed by 2 cycles of consolidation with the same regimen, KRD, followed by lenalidomide and dexamethasone maintenance therapy. And the primary endpoint was MRD negativity by flow cytometry after induction, and also along the way at each of the time points on this study. And secondary endpoints included time to progression, PFS, overall survival. So really what the investigators were looking at here was how deep could we push these responses, right? And just as background, in the studies that we discussed previously with daratumumab and lenalidomide, we didn't really focus on overall like response rates. We were focusing on PFS in our discussion, but I can tell you that most responses that patients get with single agents are not complete responses, let alone MRD negative responses. And it's fairly uncommon to achieve an MRD negative response with a single agent, milder therapy regimen like the ones we've discussed up to this point.
So what about the efficacy from this study?
Yeah, so I mean, I think we definitely saw something fundamentally different with this kind of an approach than what we saw with the other ones. We saw a very high response rate approaching 100% as patients got to post-transplant consolidation. Most of the responses are complete responses, and over half of patients on this study achieved MRD negativity. Having and that MRD negativity, as you would predict based on everything we know from symptomatic myeloma trials, was associated with a with improved progression-free survival compared to patients who didn't achieve MRD negativity. But what you can see in this panel here, I personally think, disappointingly, is that by about 4 years out, a third of the patients who were MRD negative on this study still had evidence of progression. So even at this earlier stage where you'd think there's less molecular complexity and opportunity for resistance, even with this aggressive approach, this particular trial does not seem to keep that PFS. I would have hoped that the PFS curve for the MRD negative group was flat. But it wasn't flat. We still saw patients progressing. So that's something. There have been other studies too.
So I guess the ASCENT study is another one of having a intensive therapy approach. What was this trial about?
That's right. So this was a different phase 2 study. This also looked at KRD, carfilzomib, lenalidomide, dexamethasone, with the addition of daratumumab, but without transplant. Okay, so the design of this is shown here. But again, same general backbone as the last study, as the GEM-CSAR study. And what we saw here, again, very high overall response rates. We saw a 97% overall response rate. I think there's a typo here about MRD positivity and negativity, but the majority of patients were able to achieve MRD negativity with this regimen, this was we saw a 3-year overall progression-free survival of about 90%, and that's so. What I'd say is that's better than what we saw with daratumumab alone, as we previously discussed, but it is not that different than what we saw on the ECOG study of just lenalidomide. Again, this study really did limit the patients to high risk using the 2220 criteria. So you can't really compare it to the overall results of that study because that included intermediate risk patients too. But it's hard to tell how much obviously better this is, and we will need longer follow-up, and I think a more detailed analysis of how depth of response influenced outcomes on this study. So looking forward to more updates on this study as time goes on.
And so I guess we're in an era, at least in myeloma, of CAR-T and bispecifics, and trials, I think, in Smoldering have started as well. And what can you tell us about the early results here?
Yeah, so I think not surprising that there's a lot of interest in BCMA-directed therapies for this indication. These are, a class of drugs or a group of therapies that have really changed the landscape in symptomatic myeloma, relapsed myeloma. And so when you have a therapy with those kinds of response rates in heavily treated disease, I think there's always interest in moving it up fast. And when therapies are tolerable, there's also lots of interest in moving them into the high-risk smoldering space. So there are a couple of examples here. There's the ImmunoPrism study, which looks at a couple years of teclistamab. There's the CAR-PRISM study, which is a phase 2 looking at cilta-cel, CAR T-cell therapy in high-risk smoldering patients. And I think I think what we saw here was, fantastic efficacy in terms of response rate. The response rates in both of these reports from Dr. Nadim were 100% response rates with all of the patients on both of these phase 2 studies at the time they were reported achieving MRD negativity. So that's as good as what we saw with I think I think most of us would agree was more intensive, difficult to take and administer regimens like extended therapy with KRD, with or without transplant, with or without antibodies, right? And in the other studies, so we're seeing with these we're seeing response rates and response depths that look like the curative approaches, but the intensity of the therapy for patients probably will feel more like the less intensive approaches. So this, I think there's going to be a lot of excitement around this, but it's early days. These were initial reports. We've had basically no updates on them yet. Both studies were ongoing in terms of accrual, and we don't have the PFS data yet, and we certainly don't have the long-term toxicity data. And for CAR Ts in particular, that's going to be important. We need to see what the infection rates are. We need to see what percentage of patients end up on adjunctive therapy like IVIG, as a result of being on these kinds of treatments. And we're going to need to see if there are long-term neurologic complications with these in these patients that counterbalance the benefits that we see. My prediction is we're not going to see a lot of late neurotoxicity because we're treating at lower disease burden. And we're also, I think, obviously we're getting more attuned to the issue of managing, CAR T expansion and things like that. And my guess is that probably won't be so much of an issue, but, until we get there, we don't know. This is probably the newest and most exciting thing happening in this space, but super early days.
So diet all together for us. So I guess the intensive therapy approaches are still mainly limited to trials. So let's talk about the kick the can down the road approach. What was your approach in the pre-Aquila era before daratumumab? Has that changed in the daratumumab era? How do you approach it with your patients?
Well, my own approach is I try to be pretty nuanced about this, right? One of the problems with comparing these trials, right, is the definition of high risk varies according to trial. All of the trials seem to show that it's high risk smoldering patients that benefit from some kind of treatment. But how you define high risk can vary. And an exercise that I routinely do with patients is I show them what different models predict their risk to be. And I will tell you that in my experience is that if the models have highly varying risk predictions, patients almost always defer therapy. If one model says your risk is 5%, like the Pangea model. If one model says your risk is 5% per year and another model says your risk is 20% per year, that uncertainty makes it very difficult to be enthusiastic about treatment, I think for me and for patients. So, I mean, I do that. I did that, before the latest studies, and I continue to do that. I would say that the patient's threshold for that their interest in treatment has always been the driving factor after we have a conversation about the benefit of treatment and the risks and benefits, the risks of treatment, the benefits of treatment, the studies that support it. It's always been a patient-driven decision after we lay out all the data. And I would say that there's been more patient enthusiasm for therapy when the option is a CD38 antibody rather than a daily dose of lenalidomide. And again, that is not me endorsing one versus the other or anything, or trying to compare their efficacy. I'm just saying that I think that there's more patient interest in that. That's been my observation. For me personally, I think it's actually hard to tell if there is an advantage of one versus the other. All I can say is that there seems to be an advantage to either of them versus just watching high-risk patients. And so if a patient who has high-risk disease wants treatment, we have a conversation about lenalidomide, we have a conversation about daratumumab, and then they make a decision. That's usually how it works in my practice. We don't currently have any trials open at the Karmanos Cancer Institute of the more intensive types of regimens for the extended multi-agent transplants, containing sequences of therapy. We don't have those trials open right now, and so a patient who sort of self-identifies as somebody interested in that kind of an approach, what I do is I try to facilitate a referral to a center where they're doing that kind of research, and I encourage them to only pursue such therapy in the context of a clinical study.
Well, thank you very much for taking the time to go over all this data. It's very complex in such detail, and educating the audience. It's not a simple answer as you laid out, and it seems like it's highly dependent still on the individual patient and the treating physician in this area.
Absolutely, but I appreciate being able to have this conversation with you because it's so complicated and confusing, and having the opportunity to pick it apart a little bit, I think I've enjoyed our talk.
Thank you very much.